Hello and welcome to today's surgery online session where we will focus on endoscopic ear surgery. And I am really happy that we have a special guest speaker for today who will show and share his experience when it comes to endoscopic ear surgery, especially for ossicular chain reconstruction and Stapes surgery. But before we start, as usually, I want to give you some tips to make the upcoming hour as smooth as possible for you. So please rename yourself. So if you haven't put in your real or your full name yet, please right-click on the participant panel, choose rename and type in your full name in there. To avoid any background noise, you are automatically muted. If you want to say something, or in the end, if you want to discuss something with our guest speaker, please raise your hand and then we can unmute you so that you can talk to us directly. And also, if you're experiencing some problems with your internet connection, so if the connection is not stable, we recommend that you close all programs that might run in the background, such as Outlook or MS Teams. And with this, your connection will get a lot more stable and you will be able to enjoy the videos and the presentation to its fullest. As always, please feel free to type in your comments, questions, messages in the chat. We will go through them at the end of the session after the presentation by the speaker. Good. Now, I'm really happy to introduce you to our speaker today. It is Professor Dr. Lukas Anschütz from the ENT Surgery Department at the University Hospital in Bern. So Professor Anschütz introduced actually the endoscopic ear surgery at the clinic in Bern. And he also organizes the Swiss endoscopic ear surgery course. He's the head of the Temporal Bone Laboratory at the ART-ORG Center for Biomedical Engineering at the University of Bern. And his research interests are in endoscopic middle ear anatomy, technical developments, and the refinement of under and postgraduate teaching methodologies. So he is not only very experienced with endoscopic ear surgery, he also knows how to teach it. And he will share his knowledge and experience with us today. I'm really looking forward to that. Now, before I hand over to Professor Anschütz, I want to show you just briefly the prosthesis that Professor Anschütz will implant today using the endoscope. So we will see two cases of the mCLIP arc partial prosthesis, so the one that you see in the center of the slide. This is a prosthesis that has a clip for the coupling to the Stapes head and a very flexible ball joint at the upper end of the prosthesis so that the prosthesis can follow the movements of the tympanic membrane. And we will also see one case with an mXACT partial prosthesis and also Stapes surgery with an mAXIS Stapes prosthesis. So now that's all from my side. I think I've said enough and I'm really happy to hand it over to Professor Anschütz. Lukas, can you hear us?
Yes, I can hear you very well. Thank you very much, Magdalena, for the very kind invitation and introduction. It's really an honor for me to be here today and to be able to share some thoughts about endoscopic ear surgery with you today. I prepared a small presentation, with this one. I hope you can see it.
Yes, we can see it. Looks good. Thank you.
Very good. Okay. Very good. So if you have any questions or there is something you would like to know, please use the chat and we can go through the questions at the end. I think this is the easiest for you and also for me. And yes, let's start right away. An old professor of me told me once that you should start a presentation with a citation. And I choose this citation here from Charles Darwin. It says that it is not the strongest of the species that survives, not the most intelligent that survives, but it is the one that is the most adaptable to change. And I think this citation is really well suited for the presentation of today, because we see some changes in the otology world, in the ear surgery world, and I think it is our duty to be adaptable to these kind of changes. If we look on the international level, we can see that since 2009, we have a lot of publications for endoscopic ear surgery that were done every year, and the interest is still growing every year since then. And if we have a look on the map, these are the centers where endoscopic ear surgery is performed. You can see that all over the world we have some centers, and these are surgeons who are member of the International Working Group on Endoscopic Ear Surgery, and I think we have quite a nice representation today. If we look a little bit at the principles of endoscopic ear surgery, we can say that the transcanal access to the middle ear, you see the access here through the external auditory canal, is a natural access. So we can directly go into the middle ear, and especially the attic. We don't need some external skin incisions, and the bone work we need to go there is really minimal. So we can say this kind of approach is minimal invasive. You might say, okay, it's not a big deal. You can do the same thing with the microscope as well. You're right. And this has been performed now for many, many years. I think it was introduced somewhere around the 60s or 70s. And you can see the microscope here externally, and you can look through the canal and you see in the middle ear, and you can do the surgery through the canal. The problem is that you have the light source external to the ear, and you have only a very limited view of the middle ear during your surgery. You can see here how this might look like. You see the microscope is quite big, and because you can see only a part of the ear, so the surgeons designed this post-auricular access. You can drill away the mastoid bone, and you can access the middle ear in a more wide way. In contrast to this approach, we have the endoscopic approach, where the endoscope is introduced through the canal inside the middle ear, and you can see the wide endoscopic field of view. And you can see how it looks like in Bern University Hospital. You can see the patient here. We hold the endoscope in one hand, and with the other hand, we do the surgery, and we can look, we can have a very good view on the anatomy, on the physiology, and on the disease, of course. Okay, so if you look on the advantages, of course, wide field of view, you can see here, this is just a 0-degree lens, a regular lens that we use. You can see the whole annulus is in an anatomical specimen, and you can see the whole middle ear in just one view. And if you compare in the same specimen here, you can see this, the microscopic view from a retroauricular approach, and this is the endoscopic view. You can see the topography of the anatomy is very well depictable in the endoscopic part. Also, as it was already mentioned in the introduction, the teaching with the endoscope is facilitated because the teacher and the trainee have really the same view during their activity. And we compare here the performance gain of some staff members, residents, and medical students during an anatomy training program. And we can see in the endoscope, the gain in knowledge was much higher compared to the microscope. And this is especially true for the residents. I think those who already know some things, they can benefit a lot from the endoscope because they can actually see what you're talking about, and not only estimate that they might be able to understand what the topic of the talk is. And you can also see the staff members, they're trained otologists. You can see also they had a much more gain of knowledge when they use the endoscope compared to the microscope. You can have a very good magnification with the endoscope because you can go with the endoscope as close as you want to the structures. So you can see here the stapes, you can see here the pyramidal eminence with the tendon. You can see actually how the tendon comes out of the bone. We can see sinus tympani, and if you look here, this is the ponticulus. This is a small bony crest from the pyramidal eminence to the promontory, and you can see it's a small bridge. So below there is no bone. We can look around the corner. So this is a 45-degree endoscope. You can see here the facial nerve. You can see here the cordiculus emerging from the pyramidal eminence, and you can even have a 70-degree endoscope, and you can see even the chorda tympani here in this way. You can see very nicely the cordiculus, and you can see into the antrum without having to remove one small piece of bone. And if we can do a more minimal invasive procedure, we are able to preserve the natural anatomy of the mastoid. You know, the mastoid has a special mucosa which is there for gas exchange, and we can also preserve the external auditory canal. I think this is very important also for the cleaning of the ear and for the cosmetic appearance of the patient. Of course, the endoscope also has some limitations. You will see it in the cases that I will present to you, that it is a one-handed surgery, so you need to consider your learning curve. There is a lack of the suction, so you need to have some strategies to control the bleeding. We will go through this during the cases I will show you. You have a very limited workspace in the canal, so usually the external auditory canal is about 6 to 8 millimeters in diameter, and if you use a 3 millimeter endoscope, you have only 2-3 millimeters left to operate. And if, of course, the disease is inside the mastoid, you will need a combined approach to completely clean the disease from the ear. So let's start right away with the clinical cases. So my first case is a female. She is 38 years old, and she has a recurrent right otorrhea and also a right-sided hearing loss. Otherwise, she's in good health, good condition, has no other problems, and she was sent to me with a suspicion of cholesteatoma. And of course, we can do ottoendoscopy also in the office. I think this is a very good way to, again, to show the disease to the residents, to show the disease also to the patient, and to explain what is the plan of the surgery. And you can see here a very nice case of attic cholesteatoma. This is the hammer, and you can see the rest of the eardrum is completely normal. Of course, she also had a hearing test, and you can see transmissive conductive hearing loss on the right side. Okay, so I told the patient you will need to have some surgery because, of course, the cholesteatoma needs to be removed. And before the surgery, we perform the CT scan. You can see here the coronal view. Here you can see the cholesteatoma. Here you can see it very well, the cholesteatoma. Perhaps I can go back just a second. Here, the cholesteatoma. And you can see the rest of the mastoid, very prominent sinus. The rest of the mastoid is basically normal, just a few cells with a little bit of mucosal swelling in the tip of the mastoid. So I planned for her an endoscopic removal of the cholesteatoma. And when I do cholesteatoma surgery with the endoscope, because actually you can imagine that this might be cholesteatoma, which you can remove very well through the canal, because the size does not go posterior to the lateral canal. But you never know, it might be bigger, it might be a problem with removing. So I always explain the patient, and if we need, we will do a retroauricular approach, drill away the mastoid and completely remove the disease. I think this is the most important thing for the patient. So this is the surgery. We start here. You can see the picture you saw before, infiltration of adrenaline with a little bit of lidocaine for hemostasis. And you can see I start the tympanomeatal flap anterior to the hammer, and I use a monopolar to make some dots to control the bleeding. It is very important, if you use a monopolar inside the ear, you want to use it in a very, very low power, because there is the possibility of spread of the electricity to the facial nerve. And of course, this you would like to avoid. And you see, I just make some dots. I don't cut the line of the skin. I just make the dots to have less bleeding, but to avoid retraction of the flap. And then with a very regular cold instruments, you do the incision of the skin. And here also for the control of the bleeding, this is a neuropathy, is a very small neuropathy, and is soaked with adrenaline, 1 to 1000. So it's pure adrenaline, and we use it on one hand to dissect. You will see other examples in a little bit later. And we also use it for hemostasis and can see how it nicely develops. Now we identify the annulus here, chorda tympani is here, and we can elevate the flap. We can enter the middle ear, and here the cholesteatoma is dissected away from the rest of the flap to be able to pull the flap anteriorly and inferiorly to get it out of the way for the further dissection. Now I start to remove a little bit of bone. It is important to remove the bone in a very gentle way. You can use a drill, and you can see here what I use here is a piezoelectric instrument, is a piezo surgery instrument. You can see I work under the water, so I have an excellent view, a good control over the bone removal. And the piezo has a big advantage that it is not cutting away the soft tissue. So even if I touch the chorda tympani, it would not affect it. It would not be turned in as when you use the drill. Now I can cut the incudostapedial joint. You can see I do it with a round knife. Here is the lenticular process, and I can luxate the incus. I put the chorda downways, and now I can remove the incus because I know the incus is in the middle of the cholesteatoma and I need to go more posterior, so I cannot leave it inside. You can see also it's quite eroded. Also the head of the hammer needs to be cut because the cholesteatoma is infiltrating anterior to the head of the hammer. We can then again make the approach a little bit larger to be able to really carefully dissect the cholesteatoma out of the middle ear. So you can see it goes very well, the removal of the bone. And now I search the plane for the cholesteatoma removal here. And you can see, and this is already the tegmen tympani here on top. And now again with a small neuropathy, I put it in the right plane, and we can then use it to push and dissect the cholesteatoma away from the bone. You can see here below already the dura, which is still covered by a little bit of bone, but it is very thin, of course. Then the dissection is, of course, continued posteriorly. I usually try to keep the cholesteatoma as one sac, and then when it is dissected enough, you are able to remove it in a good way. I think this is important to really try to dissect the cholesteatoma, even if you have just one hand. So the cholesteatoma goes away, and now I look into the antrum with a 45-degree endoscope. You can see here, this is the Körner septum from below. This is the lateral semicircular canal, facial nerve, and the tegmen. And we can check if there is some more cholesteatoma. And there is actually one small piece, you can see it here, of cholesteatoma, which can be removed with a suction under visual control. And we can then check again inside the situation. You can see here, oops. Sorry. We can look at the film again. I just wanted to show you this. It is quite short only. Visible. Yes, you can see here. This is the cochlear reform process. You can see the tendon. You can see it very well. The tendon of the tensor tympani muscle. This is the promontory here below. And you can see that the tensor fold is completely closed. And this might be one of the reasons why this patient has a cholesteatoma, because the ventilation of the epitympanum is actually completely closed. We saw in the beginning there was a scar in the isthmus tympanicus, and with the closed tensor fold, there is no way the air can go into the mastoid. Now I use some narrowband imaging. This is a digital image enhancement technology to see if we have some more cholesteatoma. And you can see all this tissue is probably granulation tissue. And finally, I open up the tensor fold to improve the ventilation after for the healing, a good healing process. So now I think we're all set. Cholesteatoma is gone and we can start to reconstruct. You can see I use some cartilage to reconstruct the defect that I created in the scutum. I usually use a composite graft. You can see on one side there is no more perichondrium. On the upper side, I leave the perichondrium, which then nicely holds my graft in the right position here. And the next step would then be to reconstruct the ossicular chain. And for this reason here, for this patient, I choose the prosthesis with the clip and the ball joint. You can see quite easily with the alligator forceps, the prosthesis can be positioned on the stapes and it holds quite nicely. And now with the suction, I can check if I have a good position. It holds nicely on the stapes head. And then I can check for the mobility. So it's good. You can see the reflex on the round window. I put a little bit of gel foam into the ear just as needed. Don't think we need too much here. A little bit of gel foam to hold the prosthesis in the right position and to then put some cartilage on top. You can see sometimes is because you have only one hand, you need to develop some strategies. Here I take away the cartilage from the needle with the endoscope itself, and then we can cover the prosthesis with the cartilage. I tend to use, especially in cholesteatoma cases, not so high prosthesis and a thick piece of cartilage to avoid extrusion of the prosthesis. We can put the perichondrium over the cartilage and then put back our flap. And you can see here was the cholesteatoma, nicely reconstructed, and this would be the end of our surgery. Of course, we need also to pack, and you will see the packing in the next case. Okay. So let's go to the next case. The next case actually is pretty much the same, but I think is one of the best applications of the endoscope in the autologic middle ear surgery. So I want to show it to you once again. It's a different case. A bigger is an older patient, 72 years old, has also the recurrent otorrhea. You can see the view here on the endoscope. You can see it's not so big, the cholesteatoma in the endoscopy. Hearing levels are quite similar on both sides. And on the CT scan, however, you can see that it is a bit bigger, the cholesteatoma. So you can see here, again, probably this is the end of the cholesteatoma, and it reaches almost the end of the lateral canal. You can see here it goes even a bit more into the mastoid. So it's quite a limit of indication case. That's also why I want to show it to you. And if we look on the coronal scan, we can see very similar view. You can see the middle ear is free, and here the cholesteatoma in the attic. Okay, so I scheduled the patient, as I said before, for the same kind of surgery. We can now see it here. Again, the infiltration, a little bit of adrenaline, and you see how it gets white very nicely, and you have a nice vasoconstriction to have not so much bleeding. Now I run out of stock of my monopolar needles, and you can see you can also do it without. It's not a big deal. You can cut the horizontal part with a plaster knife. It is really standard autologic instruments, so you can very well. If you want to start it in your practice, you can use the instrument that you already have. No special instruments are needed, actually, in my opinion. You can now use the regular Rosen knife to cut the flap horizontally, and we can now dissect on the bone to elevate the tympanomeatal flap towards the annulus. You see, this is the right side, and sometimes I am a little bit in conflict with the endoscope. So if you start for your first cases, I would recommend to use a left side. If you are a right-handed surgeon, is usually easier to operate. And again, with the neuropathy, I think this is really important. You can do the hemostasis and you can use it to dissect. And now we can reach the annulus. Here is already the cholesteatoma here. And we can reach the annulus. You can see how beautifully it can be detached out of his bony crest. And we can open up the mucosa of the middle ear. You can see this now is the mucosa of the middle ear. We can cut it off with a needle. I usually lift up the mucosa like this and follow the plane of the chorda tympani. You can see here the chorda tympani. This is incudostapedial joint, round window already here. We already have a good overview. Now we dissect the cholesteatoma out of the flap. Again, here the hole in the flap is quite small, but we can free the cholesteatoma here. And we know that we will need to remove quite some bone to be able to completely clean the site from the cholesteatoma. This is the short process of the hammer. And we can dissect the situation and free the hammer of the granulation tissue and make it available for the further dissection. Now I start to remove a little bit of bone, again with the piezo surgery instrument. You can see I use this underwater technique, and with the underwater technique I can see quite nicely what I am doing. If you are drilling, you cannot actually see below your drill, and I think this is a good advantage of this technique. You can also use the drill with the underwater technique. It gives you similar images and a very good control. Again, this is the incudostapedial joint, which is dissected. And here the incus is even a bit smaller than in the other case. You can see here is really just a small rest of incus, which is still here. We can cut the head of the hammer. And here the chorda tympani was really inside the cholesteatoma, so I, for security or safety reasons, I cut it away. The head of the hammer, which comes out here. And now the approach is enlarged until we can completely dissect and identify the sac of the cholesteatoma. So this is now the situation. You can see here the facial nerve. I dissect the cholesteatoma away from the stapes, from the facial nerve. You can see here this is rather inflammatory tissues, but and not the cholesteatoma, so granulation tissue, but I still want to clean it in a good way. So that's why I need to make this cut here. We can see now the situation. Facial nerve is freed. This is again cochlear-reform process with the tendon, and I put in my neuropathy once I found a good plane to then further dissect the cholesteatoma. Perhaps this is one of the only instruments you may consider to buy if you do cholesteatoma surgery. This is a very nice instrument. It's called the Thomasin dissector. It has is on both sides, has this kind of dissector, and it is very well suitable to clean the cholesteatoma from the side. And you can see again here, this is the tegmen tympani with a small dehiscence. I'm not sure if you can see it, but there was a small hole in the bone, and we do a little bit of debulking of the cholesteatoma, and then the cholesteatoma can be followed posteriorly. You can see it here, posteriorly into the antrum, and its extension into the mastoid. Now you can see this is even a little bit bigger Thomasin dissector, so I can go more posteriorly. You can see this is the situation at the end. This is 0-degree endoscope. Here is the dura, facial nerve. Here is the lateral semicircular canal. And now with the 45-degree, I can go inside this cavity, and I have here, you see, a custom-made suction. It's just a regular suction that I bend during the surgery. You can see this is scar tissue on the corner septum. And again, I use some digital image enhancement to check if I have some cholesteatoma rest. And you can see here, this is really just the granulation tissue. In this video, I show you, and this is the canal skin. This is skin. Skin is very bright in this technique. And so I can decide a little bit easier if I still have skin or not. This might be skin. So I'm going to remove it, because if you, in this kind of approach, start to remove all the granulation tissue, your surgery will take forever. But like here, you can be quite confident that the cholesteatoma is all gone, and that you can safely reconstruct your site. And so it's the same technique as you saw before, some gel foam and a piece of cartilage into the antrum in a composite graft technique. And you can see here, it was a bit too small, so I put another piece of cartilage here to really completely close up the defect. And then I show you a second technique for the application of the titanium prosthesis, here with the suction. Then the suction is closed, and you see the prosthesis holds on the hammer, and you can very gently push the prosthesis into its position. You see it's very straightforward procedure. You don't need to, it's quite fast. It's almost the original sequence. And so you can fix it very gently to the stapes. Be very careful. Don't push on the stapes too much. Again, a little bit of gel foam and piece of cartilage, which is in contact with the hammer to close up and cover the titanium prosthesis to avoid the extrusion. And a little last piece of gel foam, and then I put again some perichondrium to reinforce my reconstruction. And then I can put back the flap and close up the situation. You can see here the flap is really nice. And in Bern, we used to put some silk inside to make the dressing of the external auditory canal, some silk, and then a little bit of gel foam inside. The silk is quite nice because it is not sticky. So after 2 weeks, when I remove the dressing, the patient feels almost nothing, and we have good results. We use this in Bern for many years now, and this is a nice technique to have the canal in a good shape after 2 weeks of healing. Very good. So this was the second case, the second cholesteatoma case. I hope that you had a good impression of how this can work with the endoscope. Just if we look into the literature, we can see that the endoscope brings advantages into the cholesteatoma surgery. This is a study which was done by Professor Presutti, who is now in Bologna, in Italy. He's one of the pioneers of endoscopic ear surgery, but a very skilled middle ear surgeon and lateral skull base surgeon all the way. And you can see here, if you take same size cholesteatomas and you have a canal wall up procedure, you can see that the recidive over the years is higher than if you use only endoscopic approach. And I think the reason here is that if you spare the mastoid, you can really preserve the organ, and the buffer effect will make you have less recurrence. If we look at the systematic review performed by Lee, you can see also there is a small advantage for endoscopic ear surgery. Of course, the studies which are inside this systematic review and meta-analysis are not randomized controlled trials, but still I think there is some advantage, because very simply you can see very well and you can do a minimal invasive procedure. And if you see here, the second diagram is for the persistence of cholesteatoma. So if you forget a piece of cholesteatoma, of course, in the ear, it will grow again. And you see also for the persistent cholesteatoma, the endoscopic technique seems to have some advantage. Okay, now my next case is a case of revision surgery. He's a male. He's 68 years old and had a left tympanoplasty with incus interposition a few years ago. And he was quite happy with the surgery. And just 1 year ago, he had again some otorrhea, granulation tissue on the neotympanum. He had all kinds of drops. He was treated by all kinds of antibiotics, but there was no solution. And finally, the colleagues thought there might be a cholesteatoma or something inside. If we look at the drum, you can see here is not nice. Here in this area, there is some granulation in the neotympanum. And you can see that it has some infection. Hearing test also is not very good, especially in the low frequencies on the left side. Of course, he has bilateral sensory neural hearing loss, but these were his biggest problem was really the otorrhea. Of course, I did a CT scan here again. And you can see the middle ear is actually completely full with granulation tissue or something else. Jugular valve is quite high. And you can see here the incus, the refined incus, which was positioned again inside during the first surgery, but really everything is quite full, also the mastoid. And we can have a look at the situation here. And you can see here, this is completely filled. I'm sure if you ask a 100 ear surgeon, most of them would say, okay, you need to do a mastoidectomy for this case as well. But I will show you, of course, the endoscopic solution to this case. You can see now again the infiltration. I think this is a crucial point. Even if you do microscopic surgery, this kind of infiltration will help you to have less bleeding in the canal, especially in a case like this, which is really inflammatory. Again, the vertical cuts using the plaster knife into the external auditory canal skin. This is the lateral process of the hammer, and we can now complete our incisions using the round knife and start the dissection of the tympanomeatal flap. You can see it's a bit more bloody in this patient. He has active inflammation. He has otorrhea, really a bad discharge from his ear all the time. And now we can follow the bone and come to where the first surgery happened. He had some fascia graft initially. You can see the annulus is not very well depictable anymore. You can see here a little bit of glue coming out. It's really not a nice ear. Everything is inflamed. But you can see even this kind of case you can manage in a good way with the endoscope. You can see here this is the incus, the refined incus, which was put back again. And with the pick here, I can dissect the scar tissue away. Here we can already have a glimpse at the stapes. And so we can now mobilize these prostheses to be able to remove it. You can see now it fell down. And we need to turn it around a little bit to be able to remove it using the forceps. And then you can see here Perhaps there is some epithelialization here, perhaps not. You can see now the granulation tissue can be cleaned away from the stapes. Here, I like to use the sickle knife because it's cutting or somewhat cutting. It cuts always a little bit less and less, but it's good because you don't have too much traction on the stapes, can be removed. And you can see there is just some granulation tissue. And we can have a look at the Eustachian tube. You can see it here. Eustachian tube. I cannot really reach it with the suction, you can see, but I can see it. So it's quite nice. You saw I removed quite some of the granulation tissue, and with a 45-degree, I can look into the mastoid, and you can see there is some mucosal swelling inside the mastoid, but no cholesteatoma, nothing we really need to remove. And that's why I decided I can leave this case in an exclusive transcanal way, and we can put here now another prosthesis, is a prosthesis, also partial prosthesis, and perhaps I can quickly stop and come back. So you can see now it's not a clip here, it's like a bell-shaped connector, and it fits very well on the stapes, and you can actually you are quite mobile on how you want to position it. You could also position it below the hammer, but I like to position it this way, so it is parallel to the hammer, and you touch the hammer when it is in action. You can see here again a good coupling. The round window reflex was nice, and with a little bit of gel foam we can secure the position. The granulation tissue in the eardrum, I removed it, so there is a hole, and that's why I wanted to put a rather large piece of cartilage inside, because the main aim here is really to close up. You can see I close the situation, the cartilage goes on the prosthesis. I can check again that it is still in a good position, and then I can put back my flap, and you can see here was the granulation tissue, which I removed, and now we see the cartilage below, and the flap can be repositioned, and then the dressing of the drum. So you can see, even if the ear is not in a good condition, with the endoscopic approach, it gives you quite a good solution. So now that my last case is a woman, 45 years old. She has a progressive hearing loss since 25 years, so really long time ago, and she needed hearing aids on both sides since the birth of her second son. And so she was always quite happy with it, but now she had a deterioration of the hearing, and she came to see me, and I told her probably she has a problem with her stapes, a problem of otosclerosis, and we might be able to improve the situation with a surgery. But of course, if you look at this inner ear, she will need some hearing aids all the less, even after a surgery. So you can see I usually do a CT scan for otosclerosis. I know not many people do it, but if you look here, you can have a hint on some otosclerotic, otospongotic focus in the fissura and the fenestrum, and it allows me to exclude also a minor syndrome or any other pathology inside the ear and plan my surgery accordingly. So this is now the endoscopic approach for otosclerosis. You see the beginning is always the same. Of course, with stapes surgery, the flap and the elevation and the dissection of the middle ear is the easiest because there is no inflammation, no granulation tissue. And you can see it was in the time where I still had my needles to do the flap delimitation using the monopolar. It is a really nice tool, but as you saw, it's not absolutely necessary. And also there is some related cost because the thing, this tool, of course, is disposable. So we do the flap, we incise the skin with the knife, and the same as you saw before. You see the flap here is a bit smaller because I don't need to remove so much bone. And again, here we can start to dissect the tympanomeatal flap to find the right plane in the beginning and to follow the bone until we reach the annulus. You can see virtually no bleeding. Now with a neuropathy, we can finish the dissection of the flap and we can reach the annulus. You can see here in a very good way. I like so much this part of the surgery when we enter the middle ear. I think it's very beautiful. You can see the mucosa of the middle ear here is very thin. And we can open it up. You can already see the chorda tympani, and we can see here the round window. Of course, with the endoscope, you can see very, very well, but you will also have to work. We need to do the stapedotomy. We need to position the prosthesis. So I remove a little bit of bone here of the scutum. You can do this with a curette, even if you see the curette is probably 50 years old or something like this. Even if the curette is not so extremely powerful, it is usually enough and you don't need to drill. Now the neurolysis of the chorda, and now we can see the different ossicles. Hammer is good, incus is good, and if we check on the stapes, you can see I see it very good, but sometimes it's difficult to reach it. You can see I need to move away a little bit the chorda, and you see the stapes is completely fixed. This is the facial nerve, and now I can cut open again the incudostapedial joint. I like to use it to do it with a sickle knife, with a round knife, but you can also do it with a hook or whatever instrument you are used to. And we can see now good position, a good movement. This is the tendon is moving, of course, and the stapes not. Here I use a diode laser. You can also use only cold instrument, but I use a diode laser here to cut through the tendon. And you can use the diode laser also to cut the posterior crus. Here you can see, you can cut the bone using the laser. You can also do it with a micro drill or some Crura scissors. I think this is not so important which kind of technique you use. And so now I have a good mobility of the posterior crus. So I can check on the foot plate here and break away the anterior crus towards the promontory. And then we can remove the suprastructure of the stapes. And then I use this micro drill. Is a 0.6 millimeter diamond drill, and I can drill in a hole inside of the foot plate. You can see now it is perforated. You can see the movements of the perilymph. And then I measure the size of the prosthesis, which kind of prosthesis I would like to put inside. And then you can see here the stapes prosthesis. Now the positioning of the stapes prosthesis with one hand probably is a bit more difficult. And I usually don't put it in with a forceps, but I just position it somewhere. And then with the needle or with a hook, I can push it gently to let it fall in. You saw just now it fell in the hole and is now attached to the long process of the incus. I think it's very important not to push on the foot plate while you try to put inside the prosthesis. We can check again the right positioning. And I'm quite happy with the prosthesis as it is now. You can see in a good position. so that we can close. Let's see again. So we can close the prosthesis on the long process of the incus. The crimping. I like this quite broad, this broad side of the prosthesis, because it allows me to really have a good contact to the incus without compromising its vascularization. Then we can put back the flap, put in our silk, and the surgery is finished. So I think we are on a good way. So the take-home message from my side would be that the endoscope brings innovation into ear surgery. It provides you excellent visualization, and you are able to provide minimal invasive procedures to the patients. The patients will be forever grateful because they have no scars and they are fit again in a very short time. Then the endoscopic ossiculoplasty with the titanium prosthesis is quite straightforward, as you just saw. And it is very important that you know your learning curve. If you start off with endoscopic ear surgery, even if you have a lot of experience with ear surgery, you should probably not start with stapes, but start with a tympanoplasty, with a good canal, with a posterior perforation, a left side if you're a right-handed surgeon. And you need to know the microscopic or exoscopic approach for the more bigger cholesteatoma. If you have a problem in the mastoid, or if you do a cochlear implant, I think if you need to drill away a lot of bone, the microscope or also exoscope is very important. So that was it from my side. Just perhaps a little advertising. We run a meeting in May. It will be in Ascona. It's a very beautiful part of Switzerland. And we extended the poster deadline until the 15th of April. So if you want to submit some abstracts, we will also give travel grants and abstract poster prizes to the best submissions. You can find all the informations on this homepage. And if you're interested in endoscopic ear surgery, you can join us on 4th and 5th September in Bern for a combined hybrid endoscopic and microscopic ear surgery course. So thank you very much for your attention, and I'm very happy if you have some questions to answer them now.
Thank you, Lukas, for these very impressive views into the middle ear. It's really, really nice what you can see with the endoscope. And every time I see something like this, I'm really like, wow, really nice. So again, the call from my side to the audience, if you have any questions, please use this opportunity to ask the expert since you have him here. And I'm sure he will be very happy to answer your questions. So I'll just look at the chat. So there's a comment. Thank you, very educational cases from Sören. Thank you for watching. Really informative. Yeah, thank you. A lot of, okay, Uwe Steinhardt has 3 questions. So for those of you who don't know Uwe, he's actually, he has been in the PMEI business for more than 20 years, and he has developed and manufactured the prosthesis that you saw today. Uwe, do you want to unmute yourself, or do you want to, I think you would, right? Yeah.
Okay, hello together. Hello, Professor Anschütz.
Hello,
I have
nice to meet you.
3 questions. My first question is, you use gel foam. Do you really think this gel foam is necessary in case of you have a clip on the stapes? Because I don't fear the migration or the tilting of the prosthesis. Do you really think gel foam is necessary, or is this just for being super safe?
Thank you for the question, which is very good, of course. When I cut the video, I asked myself the question also, because of course the clip holds the prosthesis in a good way. But because the ball, so you have I also used the clip without the ball, so there I would not put some gel foam. But with this ball joint, I would like to have the plate a little bit stabilized, and that's why I used the gel foam there.
Okay. Because gel foam is not so common, at least in Germany, I think.
If I can say something on this, it is a big debate in Germany and I think all over the world. And there are two groups of people: the one they use it and they would never stop, and the one they don't use it and would never do. And there is just a very there are some randomized controlled trials around, and it makes no difference. So it's really not just too much the
price
of a thing, I think.
Just the price of the gel foam, but that's another topic. And then my other question is, do you see any advantage? But I do not want to make advertisement for the prosthesis. It's just a question: do you really think there is an advantage of this movable head blade in case of using an endoscopic approach? Because the view is so brilliant to the Stapes, I think.
So to be very honest, when they first asked me to make this kind of presentation here, I said, well, it's not possible to use this kind of prosthesis with the endoscope.
Yeah.
Because also the clipping, and you have only one hand.
Yeah.
And then I used it with the microscope, and I noticed that, of course, also with the microscope, you would not have used the second hand to stabilize the stapes, and it is very smooth. So that's why I now use it with the endoscope as well. And the ball actually is nice because you can put the ball, you can flip it down, you can take it as you saw with the forceps, and then you can still see very well where the stapes is below. Sometimes if you have a big head of the prosthesis and is not movable, then you might have it might be more difficult to position the prosthesis really on the stapes head. And like this is a very straightforward procedure.
Okay, and so you changed your opinion, you think? And the last question
with the experience.
The last question is, which came up. There are prostheses on the market which are getting heat activated to getting in contact with this long process of the incus. You know,
so the stapes.
Yeah, for the stapes. To the stapes prosthesis. Yes. Do you think an endoscopic tip is warm or heat? There is heat on the tip. Do you see the risk of getting a closure of the prosthesis loop before you have the prosthesis in place?
Oh, that's a good question. I also use this kind of prosthesis, but I never had this kind of problem. You know, the endoscopic approach is some people, they use a holder, and then you have a lot of heat inside of the middle ear. But if if you have it in your hand, it goes in and out all the time. It's like ice hockey. So the endoscope is on the rink only for very few seconds and then goes up out again and cleaning. So I don't think there is a big heating of the middle ear in this kind of technique.
So you don't see the risk of that. Okay.
I wouldn't.
Thank you.
But I haven't experienced it, at least.
Thank you.
Thank you for the questions, Uwe, and thanks for answering, Lukas. There's a related question to the heat topic in the chat from Francisco Gonzalez. Sorry if I didn't pronounce it correctly. The question is, any facial nerve post-op issue due to the heat of the endoscope and the diode laser?
So this is a very good question, and there have been some investigations of this also. And if you leave the endoscope inside the middle ear for 1-2 minutes, it heats up the middle ear up to 60-70 degrees. So I use the endoscope only on a very low light intensity. So if you put it to 30 or 50% of your light sources with the modern light sources is really enough. And as I said, it's very important, in my opinion, to it is very dynamic. You remove it all the time, and then you use the suction, and so it's a very dynamic approach. So I would not fear the heating. And so far, I had never some facial nerve palsy, and I use the endoscope now for many years. And I think with this kind of approach, there is nothing to be feared. The diode laser, of course, the diode, you know, it has a very short action. So if you shoot with the diode laser on the facial nerve, probably you will be able to make a palsy, but you shouldn't, of course, shoot into the facial. And another thing with the diode laser, if you use it to make the platinotomy, the hole into the foot plate, the diode is not absorbed immediately. You know, CO2 laser is absorbed immediately. It cannot penetrate, but diode can. So you can theoretically also make damage on the medial side of the vestibule. So that's also why I use the micro drill. I have good experience with that, and it works quite straightforward. Sometimes even better than the diode, because because you may have to shoot many times with the diode, and with the micro drill is really nicely controlled.
Okay, great. Thank you for the answer. So I don't see any more questions in the chat, and we're already past 4 o'clock European time. So I hope everybody enjoyed the session today. Thank you so much, Lukas. I think it was really, really very interesting, and also very educational also for the audience from the feedback that we've seen in the chat. So thank you very much. I want to say a few words on the next session that we will have on May 3rd, which will be with Professor Dr. Diana Arweiler-Harbeck, with the topic simultaneous bilateral cochlear implant surgery in children. So please be sure to register also for this session. It will be very exciting also, of course. And another thing that I want to mention at the end of the session is actually the surgical video library. So here you can really find HD hearing implant surgical videos with step-by-step narrations and guides by experienced surgeons. So be sure to register also for this video library with this QR code or the link that you can see on the slide. So, but with this, at the end of today's session, thank you again, Lukas. Thank you to the audience and for participating and for your questions and comments. See you next time. All the best. Bye-bye.
Thank you.